students. I'm going to go into the urinary and renal lectures, just kind of give you an overview here of lower UTI, and then we'll talk about upper UTI. So the people at risk for a lower UTI are women, especially because they have a shorter urethra and it's proximal to the rectum. Postmenopausal women or anybody with low estrogen is going to be at risk. Anybody that wears synthetic underwear, so you're supposed to wear cotton underwear, your granny panties, are good. So bowel incontinence, anybody with bowel incontinence, anybody with diabetes is going to be at risk for UTIs. Of course, indwelling catheters puts a patient at risk, and the longer the catheter in, the more chance that they will have an infection. Anybody with a neurogenic bladder, we learned about that in our stroke, Parkinson's, and spinal cord injury lectures, and of course, older adults. The most common pathogens, really just remember E. coli. That's acute pneumonic, but really most of them are going to be from E. coli. Inflammatory conditions that comprise UTI. So cystitis, so that's inflammation of the bladder. Urethritis, that's inflammation of the ureter. And prostatitis, and that's inflammation of the prostate. So all these things can create a lower UTI. Or I should say those conditions, okay? So the UTI symptoms, you can remember the mnemonic, fun-wise, which is anything but fun. So F stands for frequency, U stands for urgency, N stands for nocturia and nasty smell in urine. W stands for weak stream, and this would be like with prostatitis. I stands for intermittency, which again, that's with prostatitis. Itchy perineal area. S stands for straining. STIs can cause the same signs and symptoms, and E stands for emptying incompletely, so voiding in small amounts. The UA is going to show an infection if somebody has a UTI. So they may have bacteria present. The leukocyte esterase is going to be elevated. Okay, so leukocyte esterase is like an enzyme that's secreted by the white blood cells. So that's going to be elevated, indicating infection. Pyuria, which means a WBC greater than 10, is going to be present in the urine. Nitrates are present in the urine, and they're present in the urine when there's E. coli. So that's a good indicator of an infection. The WRBCs are going to be elevated. So hematuria is common in UTIs. And also the pH is the other thing. It may be elevated in some infections. All right, older adults. Older adults may become confused, and I think you know this, incontinent, which is a new incontinence. So if you normally care for somebody that's in the older age group and they become confused and have new onset of incontinence, it could be due to a UTI. They may develop nocturia, so that's getting up in the middle of the night. And what we worry about in over adults is something called urosepsis. You haven't had your shock lecture yet, but this is common. So they will have tachycardia, that's the first sign of shock or sepsis, hypotension, tachypnea, and then fever as well. So you're watching for that, those signs and symptoms. And pregnant clients with UTIs need to get treatment as soon as possible, especially if it's an upper UTI, because that can result in preterm labor. So in other words, they can go into labor. The treatment includes antibiotics. So, for example, penicillins or cephalosporins, nitrofurantoin, I can't even pronounce that, and sulfa drugs. So if anyone getting any of these drugs has urticaria, which is hives, stop the infusion or stop the medication right away. Quinolones, that's like your Cipro. Report ankle pain because they can damage their Achilles tendon. They're at risk for sunburn, so that is called photosensitivity. Don't get that confused with photophobia. Photophobia means like bright lights hurt your eyes, okay? And they need to take it with a full glass of water. Anybody on antibiotics needs to report watery diarrhea because they may have developed C. diff. And Fenzaparidine is a urinary analgesic, and it will turn the urine orange. It's a great drug if you have a UTI because it works immediately. How you evaluate that it's working, though, is not because it turns the urine orange. It's because it decreases the pain or eliminates the pain of the UTI. So that's how you would evaluate that. With your client education, you want everybody to finish antibiotics. They need to empty their bladder every 3 to 4 hours. In other words, it's very difficult being a nurse, right? Because we do hold it longer than 4 hours. People, or women especially, should avoid before and after sex. They should drink a lot of water. Unless it's an older adult, you might have cautious hydration because they may not be able to drink that much. People can take cranberry-based products to inhibit bacterial adhesions. In other words, to decrease the frequency of UTIs. Teach women, especially, to wipe front to back. No bubble baths, no sitting in wet bathing suits. Do not wear underclothes that retain moisture. And so that's like anything that retains moisture, any kind of synthetic material. And do not wash underclothing in strong detergents. Now I'm going to jump to UTI, and I've made some observations about, I know how to distinguish an upper UTI, a lower UTI from an upper UTI. Okay, so acute pyelonephritis is an upper UTI. And when it's acute, it's most often only affects one kidney. And it's because a UTI, a lower UTI, from E. coli, ascends up through the ureter and gets into the renal pelvis here. And so they can have these pockets of pus and inflammation. Over time, if this continued to happen, they could result in chronic pyelonephritis. So E. coli is the most common organism that causes this, and it's an ascending infection of the kidney and renal pelvis. Usually it happens in young women, not voiding before and after sex. So your symptoms, again, are your fun-wise. And those are the assessment findings. So the symptoms are like a UTI. They can have low back pain as well. But what's different in pyelonephritis is they will have costal vertebral tenderness, CVA tenderness. That distinguishes an upper UTI from a lower UTI. And so they would just percuss on the costal vertebral flanks here. And that's how you tell the difference, okay? But they're still going to have all the other signs of a UTI, like burning, perineal itching, frequency, pyuria, foul, nasty smelling urine, and then dysuria and hematuria. Those symptoms are the same as UTI. And then what's different is the CVA tenderness. And usually patients with a lower UTI don't have nausea and vomiting, but you can with pyelonephritis. They could have a fever and chills. They're definitely going to have sinus tach and tachypnea, and they could develop urosepsis if they get, if it persists, and the symptom of that would be then they would get hypotension. Now in older adults, same as lower UTI, look for confusion, new onset of urinary incontinence. They may not be able to tell you they have dysuria, but they will be getting up and having nocturia, and then they may develop anorexia. So that's our older adult crew. And then acute pyelonephritis can turn into chronic pyelonephritis. Now, a couple of differences. With chronic pyelonephritis, it's usually due to a chronic condition, a chronic situation, and both kidneys are involved. Okay, it's bilateral, and it's going to end in end-stage renal disease. End-stage renal disease is stage 5 chronic kidney disease. So we're not going to go into a lot of detail. I'm just going to show you a couple pictures, okay? Because I'm going to talk about chronic kidney disease later, so you don't need to learn it twice. So here's a picture. So here are some of the causes, if you're interested. Neurogenic bladder, because the urine is static. Okay, NSAIDs, if you take too many NSAIDs. Any kind of obstruction. Say somebody has chronic kidney stones and they're chronically obstructing the urine flow, and then the urine backs up into the kidney, they can get chronic kidney disease. Anybody on bed rest, like quadriplegics, right? That comes to mind. Anybody with repeated UTIs, that's a big risk factor. Sometimes people are born with problems in their ureter, like it's supposed to go one way, but they may get reflux. They may need surgery for that. People with immunity problems are going to be at risk. Anybody using IV drugs. So they will develop nocturia and a high potassium, hypertension, a fixed specific gravity, but don't worry, these are all symptoms of chronic kidney disease that I am going to talk about later. I'm going to talk about the UA again. Now, this is going to be the same UA as in a UTI, okay? So they're going to have RBCs, and they're going to have leukocyte esterase and nitrates in the urine. High BUN and creatinine, and that goes with the chronic kidney disease. Okay, imaging for either kind of pyelonephritis. So a KUB, that's going to look at the structures. Maybe they have renal calculi that can detect that. Ask your patient to remove their jewelry and make sure they're not pregnant. Okay, for avoiding cystourethrogram, they're going to have contrast dye put into their bladder via a Foley catheter, or like a straight cath. Their bladder holds on, and then they void, and they take pictures of the contrast dye coming out. Now, this isn't absorbed, so you don't have to worry about damaging the kidneys. Renal scans, they would do this to look at like the glomerular filtration rate, or to see how well the kidneys are perfused, and that's safe for renal patients. It's not going to damage the kidneys. The IV pyelogram can damage the kidneys, so you're going to call the provider or radiologist if they do have an increased creatinine. The urinary output needs to be 0.5 milliliters per kilogram per hour. Okay, so if it's less than that or less than 30, that's what you probably used to let them know, because they're going to need IV fluids. You want to hold metformin before an IV pyelogram 24 hours before and 48 hours after. Or if they have a CAT scan with dye, that's another reason. Okay, so that would go for any type of patient with kidney disease. You want to protect the kidneys. Okay, I'm going to talk about acute glomerular nephritis. Now, I do have a nephrotic lecture here, but I'm not going to talk about nephrotic syndrome, and it's not going to be on your exam. I'm going to tell you why. Because it's not in the adult med-surg ATI book. It is in your textbook. But the reason I choose not to teach it to you now is because you're going to learn it in pediatrics. And this unit is a monster. Your exam 3 has a lot of information. I'm not even done preparing for it yet, and I'm already overwhelmed. So you need to start studying for exam 3 early. There's so much content. I've got to change it. So acute glomerular nephritis, it can be seen in children and adults, and it occurs after an infection in the body forms an antibody-antigen complex that attacks the glomerulus. So it's usually like a strep infection. Okay, so the signs and symptoms, you can remember the mnemonic had strep. So H stands for hypertension, A stands for ASO, antistreptolism, and that's something you would detect after somebody had strep. D stands for decreased glomerular filtration rate, GFR. The normal GFR is 125 milliliters per minute. So it's going to be lower than that in somebody with glomerular nephritis, and they'll have diffuse abdominal pain. They'll have swelling in the eyes and face, and that's because they're losing albumin in their urine. And when you lose albumin, it makes you puffy, okay? T is for T-color urine. It's also described as smoky or rusty. R for recent strep. E for elevated BUN and creatinine. And P for proteinuria, because they spill protein in their urea. So the labs you got to know. Now, these are going to be very similar with the GFRs decrease and the BUN and creatinine is increase with people that have chronic kidney disease and acute kidney injury. In addition to that, the albumin in the blood is going to be decreased because they're secreting it in the urine. Um, and then they probably are going to want to do a kidney biopsy to see what caused it or see how the kidneys are doing. So, anyways, you need a consent. They're going to need to be MPO beforehand, and they need coagulation studies. The kidney is very vascular, so they could bleed to death. That's why this is an important. You need to know how to prevent the bleeding after the test. So positioning is going to be prone with a pillow under the abdominal area and shoulders, and they'll be on like the x-ray bed because it's done in like vascular lab, and explain to the patient they have to remain still, and they'll hold their breath while the provider's doing the biopsy so they don't get a pneumothorax. So post procedure, they need to be on bed rest for 24 hours, and that's to prevent bleeding. They need to be supine. You're going to take procedural vital signs. Okay, so those are those frequent sets. Q 15 minutes times 4, Q2 times 30, and then Q4 times 1 hour. They need pressure to the site for 20 minutes because you want to prevent bleeding. H&H 8 hours after. Monitor the urine output. You're going to expect pink to rosé urine after the procedure. No heavy lifting or strenuous exercise for 2 weeks. And treat hypertension aggressively, because if somebody has a high blood pressure after having a kidney biopsy, they could bleed out. All right, so treatment depends on the symptoms. And if they're oliguric or anuric, they're at risk for fluid overload. They're also at risk for getting confused. So you're going to restrict protein, potassium, magnesium, phosphorus, and fluids. The typical fluid restriction for somebody with kidney disease is you take the 24-hour urine output, or the output the day before, add 500 and 600 milliliters to that, and that's going to be the input allowed the next day. So let me explain. Say my patient put out 2,000 mLs in 24 hours. So the next day they can have 2,500 to 2,600 mLs. You want to monitor the daily weight. They're going to get steroids and immunosuppressants. They may have plasmapheresis, and they're going to be on bed rest because usually they have a lot of edema. All right, for chronic glomerulonephritis, this develops over 30 years, and it ends with end-stage renal disease. So the symptoms are going to be the same as chronic kidney disease. Uremia, fluid overload, and fluid and electrolyte disorders is something you would be monitoring for, and I'm going to talk about that in a different lecture. All right, now some of the diagnostic tests. I kind of talked about the UA a little bit. It's best to obtain the first void in the AM because it's the most concentrated, and you want to get a midstream catch. Okay, and if it has protein, it could be nephrotic or nephritic syndrome, like glomerulonephritis. RBCs could indicate glomerulonephritis or infection. Ketones usually means people with diabetes 1. CAS should not be present. Low specific gravity, this happens in DI, kidney disease, diuretics. High specific gravity, this happens in SIADH. Leukocyte esterase, I talked about that being for infection. Nitrates, E. coli. WBCs present mean infection, and pH high or low can mean infection. Now, the creatinine clearance is a test that you have to do a 24-hour urine from, and it mirrors the glomerular filtration rate. So we don't really do this that much anymore. I mean, I don't know if you've ever been involved in a 24-hour urine, but it's real easy to lose this, put it the specimens, and then you have to start over from the beginning. Okay? So the urine has to go on ice. You start it, you dump the first specimen, and then you collect all the specimens in the next 24 hours for that urine output, and put a sign in the bathroom that the patient is doing a 24-hour urine. The creatinine, 0.6 to 1.2, I think you know that. So when it's elevated, you're going to see that. And this is just more reliable than BUN because the BUN can be elevated in a lot of different things like dehydration, um, eating a lot of protein, GI bleeding. So the BUN normal is 10 to 20. Of course, you don't have to know the normals anymore because we're going to put them on the exams for you. Okay, I kind of already talked about most of these tests. So, kidney biopsy, I talked about the main things of preventing bleeding. Um, and then KUB, no jewelry, and check for pregnancy. CAT scan, the main thing is ask about a shellfish allergy. Make sure they're urinating. Check the BUN and creatinine and whole metformin if you need to. Same with MRI minus the check for shellfish allergy because they use gadolinium as the dye and that doesn't contain iodine, but it's still damaging to the kidneys. So you might, if somebody's on metformin, you are going to hold that. And then renal scan, I talked about, that's safe for kidney disease. Pyelogram is iodine based, so you have to make sure that they have enough fluids and watch if they have an increased BUN and creatinine. All right, now I'm going to talk about kidney stones, which are also called nephrolithiasis. So they originate anywhere in the kidney, but can be found anywhere in the urinary tract because they can travel down the ureter into the bladder. So urolithiasis is found in the bladder. And stones that form in the urinary system can be the risk factors can be based on many things, like it could be their age, hereditary, race, gender. Sometimes it runs in families. It could be your occupation, like if you're a nurse who can't drink all day because you're so busy. Being dehydrated is one of the risk factors of having kidney stones. So the symptoms, oh my God, the pain, people have told me it's worse than childbirth. So they're going to have stomach pain, back pain, nausea, vomiting, fever, blood in the urine, and dizziness. They'll be diaphoretic. They'll have tachycardia, tachypnea, hypotension if they go into shock, or hypertension because the pain is so bad. Their urine can be described as rusty or smoky. And if they become oliguric or anuric, that's a medical emergency because they can end up getting hydronephosis, and you don't want that to happen. So the nursing management, they're going to need pain medications, so ketorolac and morphine. You can use hot baths and moist heat to the area. You want to encourage a lot of fluids to flush out the kidney stones. You want to encourage ambulation, which is probably the last thing they want to do when they're in that much pain, but it helps to pass the stones. You're going to give IV fluids to flush out the stones. Monitor the INO because you want to know if the urine output decreases. You're going to strain all urine because you need to send those kidney stones to the lab so that they can look at it for analysis to see what kind of stones they are. And then once you've done that, you don't have to send it anymore. You don't have to strain anymore. You strain before you know what kind of stone it is, and you strain after an ESWL. Those are the 2 times you strain. Risk factors. So family history of renal stones is a risk factor. Immobility is a risk factor. High calcium is a risk factor. Obesity, and certain foods, which I'm going to get into. So there's basically 5 types of stones, and most of them happen with men, but except for this struvite one, that usually happens in women who have UTIs. So the most common kind is calcium oxalate. So I would know the dietary restrictions of that one. The other one is calcium phosphate, cysteine, uric acid, and struvite. So what can happen because of kidney stones? They can cause obstruction. They're going to cause hematuria. Patients could develop kidney infections because of it, like pyelonephritis, and they could get hydronephosis. Now, this is a kidney. See, there's a stone right here, and this is filled with the urine. It's going to back up into the kidney. So this patient right here may need to get a nephrostomy tube, which they would get in like interventional radiology. and that would drain this urine out to try to protect that kidney, and possibly they could retract the stone. But you got to keep your eye on the urinary output. A nephrostomy tube is something you never irrigate without an order. So the patient teaching depends on the kind of stone. And I'm just going to go over calcium oxalate because that's the most common kidney stone and the one I've seen the most questions about on ATI. So they need to avoid or limit spinach, black tea, Coca-Cola products, or like chocolate, all the good stuff, right? Pecans, rhubarb, and limit sodium. The pH of their urine will be high. Now, if the patient can't pass a kidney stone, they may have to go for extracorporeal shock wave lithotripsy. So, when they come back from this, you're going to expect flank bruising and hematuria. You need to monitor for dysrhythmias after this procedure because they're getting electric shock through their kidney, which could not damage, but it could interrupt the electrical system of the heart. So they may get dysrhythmias. So look for dizziness, weakness, fatigue, decreased exercise tolerance, palpitations, irregular pulse, dyspnea, and syncope. You want to strain all urine to determine if the stone passed, and medications keep up with, they'll get an alpha blocker like tamsulosin or a calcium channel blocker like nifedipine to help with the colic. All right, benign prostatic hypertrophy. Okay, now this, I see a lot of questions in ATO about this. So what happens with this is that the smooth muscle and epithelial cells of the prostate gland start to multiply, and it's a normal part of aging in males. So that's going to impair the outflow of urine, and it can result in prostatitis. So your risk factors of BPH include born male at birth, and that's important because sometimes if somebody has gender reassignment surgery, the prostate stays in and they can still develop problems with their prostate. Urinary stimulants like alcohol and caffeine, anybody obese with a BMI greater than 30, anybody on the standard American diet, anybody's father who had BPH is at risk, anybody with metabolic syndrome is at risk, anybody with diabetes and heart disease, and prostate cancer is not a risk for BPH. So the signs and symptoms are fun pissed. So they're not having fun, so they're pissed, okay? Because it's not fun having this. They're going to have frequency. They're going to have urgency. They're going to have nocturia, sometimes greater than 4 times a night they're getting out of bed. P stands for poor stream of urine. I stands for intermittency. So the urine starts and stops suddenly, and they have an inability to void. S stands for sense of not being able to empty the bladder completely. S stands for straining to urinate and the need to apply pressure. E stands for ejaculation pain or pain upon urination, so dysuria. And D stands for dribble and dysuria. So those are the signs and symptoms somebody with BPH is going to have. So the patient can also develop kidney disease if the urine continues to go back up into the ureters. So you're going to look at the UA, you're going to see infection, signs of infections. CBC, your WBCs will be elevated if somebody has an infection. If they have kidney disease, their BUN and creatinine will be elevated. And then the digital rectal exam, the provider will do that, will show an enlarged smooth prostate. So with the prostatic specific antigen, so the PSA blood test, it has to be drawn before somebody has the DRE, digital rectal exam. They can't ejaculate 48 hours before because it's going to elevate the level. There's no food restrictions. They need to start getting this done at age 50. And the PSA increases with age. That's an expected finding. And a UTI in the last 6 weeks can also elevate the PSA. Anybody with a value greater than 4 needs to be investigated. So with a high PSA, you could either mean prostate cancer, BPH, or prostatitis. Medications, your DHTs, so finasteride, They may take that for may take 6 months for it to kick in and work. And then tamsulosin is another drug, and remember that causes orthostatic hypertension. So what they may end up undergoing is a TURP, transurethral resection of the prostate. I used to take care of a lot of these in the PACU, and it's like Groundhog Day with them because they wake up and they feel like they have to pee, and they're basically trying to climb off the stretcher. That's how much they feel like they have to pee. So the post-op care involves a continuous bladder irrigation, which we also call a Murphy drip. So this is how much fluid you put in. So these bags are typically, it's usually saline, but these bags are typically 3,000 mLs each. So you would hang 2 of them at a time because you go through them quickly. And they would, you infuse them into the Foley catheter. Now, what you want to do is keep the flow going, okay? So you're trying to flush out all the pieces of the prostate that get like flagellated off when they do the surgery, and any blood clots, okay? Now, it's real easy for this Foley to get clogged. That's why you have this continuous bladder irrigation. It doesn't, like, they can still get a clot even if you're keeping up with the irrigation. So you're going to be emptying the Foley a lot. But it's a 3-way catheter, and it has a 30 to 40 ml balloon, and you tape it to their leg to maintain traction on the surgical site. You're going to monitor the INO. We keep the urine a rosé color, so light pink, by adjusting the rate of the continuous bladder irrigation. And it's a 3-way irrigation, so keep it patent. Now, urinary output equals your return, how much you emptied in the bag minus the amount of solution. So, for example, say I put 2,000 in and I got 2,500 out of my Foley bag, my urine output is 500 mLs. Bladder spasms could indicate retained pieces of the prostate, so you're going to look for bladder spasms. Irrigate, if you have a patient with bladder spasms, you're going to irrigate the Foley with 50 mLs in a piston syringe and call the provider if unable to dislodge the clot. All right, they're high risk for DVTs. So after you DC the 3-way catheter, the urine should turn an amber color within 3 days. And they cannot do heavy lifting or have sex for 2 to 6 weeks, so increase the fluids. Okay, so make sure you know the risk, how to do the PSA, the diagnostic test, but continuous irrigation is typically a popular proctor topic. Okay, now I'm going to talk about acute kidney injury and chronic kidney disease. Now, before I talk about these conditions, I'm going to tell you about renal function. And we're going to go by the mnemonic a wet bed. And the reason I'm teaching you this is because this can be applied to many conditions. You're going to be so overwhelmed with everything you have to learn for exam 3. This is a good way to learn it. So, A stands for acid-base balance. That's the kidney. That's a kidney function. And what you're going to find in kidney disease is metabolic acidosis with Kussmaul respiration. So they're going to have a low pH and a low bicarb on their ABGs. If they have severe acidosis, they'll need dialysis. Or you're going to treat whatever's causing, if you'll treat the underlying cause if you can. W is water removal. So our kidneys are responsible for removing water, excess water from the body. So if your kidneys are not working, you're going to see signs of fluid overload, such as crackles, tachypnea, tachycardia, shortness of breath. You're going to see that pink frothy sputum, low O2 sats, anosarca is edema all over, feelings of impending doom. What you're going to do is increase the head of the bed to high foursquare if you feel somebody has water overload or fluid overload. Put O2 on. Remember, you increase the head of the bed first and then put O2. If somebody is still making urine, they can get furosemide to see if they can get that water off. Mad Dog is a mnemonic that you would use for somebody that has fluid overload, you want to give them, and they have pulmonary edema, you want to give them morphine. That's a really good drug for pulmonary edema. Aminophylline, we don't really use that much anymore, but that's a xanthine. Digitalis helps the heart beat fat or contract stronger, I should say. Diuretics like furosemide, if the patient's still making urine. If the patient is not making urine and they have fluid overload, signs of fluid overload, they're going to need dialysis. O2, blood gases, and fluid restriction. And I talked about what the typical fluid restriction is in kidney disease. E is for erythropoiesis. So your kidney secretes erythropoietin, which stimulates our bone marrow to make red blood cells. But if the kidneys are not working, the patient is going to be anemic and they're going to need epigen. Okay, so epigen, you're going to administer that subcutaneously. It needs to go in the refrigerator if you're not going to use it right away. And then monitor for hypertension and headache, seizures, DVT, and an MI, okay, because it can make the blood quite thick. T is for toxin removal. So medication adverse effects. So like say somebody is on digoxin, they could become toxic on a normal dose if they have kidney disease. The toxins that the kidney normally removes is the BUN and creatinine. So if it can't do that, the patient, when you have a high BUN and creatinine, sustains uremia. And I'm going to talk about that a little bit later. But they will also have a low glomerular filtration rate. So you're going to monitor for the signs and symptoms of uremia and a low protein diet to prevent uremia. That's another thing you'll do. B is for blood pressure control. So people with kidney disease can't control their blood pressure. They usually have hypertension. They're treated with ACE inhibitors, calcium channel blockers, and beta blockers. And remember that ACE inhibitors and ARBs can increase the potassium level. E stands for electrolyte balance. So your kidneys maintain our electrolyte balance. Now, if your kidneys can't do that anymore because they're damaged, the patient's going to have a high potassium and they're going to be at risk for dysrhythmias. They're going to be they'll have a high phosphorus, so they'll be at risk for osteodystrophy, which means they're going to get fractures really easily. They'll have low calcium because phosphorus and calcium have an inverse relationship. High magnesium and high sodium, so they need a low sodium diet. For high potassium, remember that's treated with KIND. So Kayexalate, insulin and dextrose, sodium bicarb. Patients with high potassium should not use salt substitutes because they have high potassium. They may need dialysis if they are anuric or not putting out urine, or diuretics if still producing urine. For high phosphorus, patients need to avoid food high in phosphorus, such as dairy, soda, nuts, and meat. Give phosphate binders with all meals, sevelamer, and all based antacids, aluminum-based antacids. Okay, for low calcium, we're going to encourage calcium in the diet. They may take vitamin D. High magnesium, we need to avoid magnesium-containing antacids like Milkamag. Okay, vitamin D activation is going to cause low calcium. Make sure you remember how to assess for low calcium. Again, they'll take calcium and vitamin D supplements. So the conditions that a wet bed findings occur in includes the oliguric stage of AKI. Now, I did a lot of questions in ATI. And in ATI, if somebody's in the questions didn't always tell you what stage of AKI were in. So if you get questions about AKI, assume it's in the oliguric stage. The oliguric stage of acute glomerulonephritis, chronic kidney disease, chronic pyelonephritis, and chronic glomerulonephritis, and polycystic kidney disease. So all these conditions that we talk about for this next exam are going to present like a wet bed. Okay, so that's important. And I'm going to go over the signs and symptoms of uremia with you right now. So uremia affects essentially every body system, and we're going to be learning about the liver too in exam 3, and they kind of have the same signs and symptoms. Okay, so in the poetic system, they're going to have anemia. So they'll be tired, pale, and breathlessness. They'll have shortness of breath. With uremia, it makes the platelets not work. They may have a good platelet level, but the quality of the platelet is not good. So they're going to be at risk for bleeding. Their skin, people with renal disease have a skin color. It's tan gray. We call it sallow, SALLOW. And they'll have pruritus because of this, the ammonia under their skin. With their GI tract, they're going to have vomiting, anorexia, and nausea, and diarrhea. Endocrine, they'll have amenorrhea. Men will have erectile dysfunction and infertility. And then with the CNS system, so if they have severe uremia, that's going to make them confused. That's why we put them on a low protein diet. They can have hypertension and heart failure. Renal osteodystrophy, that's what it's called. Remember, I was talking about the high phosphorus that can cause that, and low calcium. So they're going to have bone pain. They'll have osteomalacia, and they're going to be really at risk for bone fractures. Okay, we'll take a break there. I want you to absorb the wet bed because we got a lot of things to talk about that the wet bed relates to.